So welcome again. It's me again. Research updates here on juvenile systemic sclerosis, just making sure you're in the right spot. All right, so going to go over some clinical data from cohort studies, a little bit about the Scorecard large study, and some ongoing studies and new studies. So talking about the legacy care registry, that was several years back at this point, about 7 years ago that started and then kind of closed, and then we started the new care registry. But basically, CARA is the Childhood Arthritis Rheumatology Research Alliance. It's a collaborative group of pediatric rheumatologists in the US and Canada from at least 60, but probably more than that now, different academic sites. And at that time, it was around 280 rheumatology attending and fellows. We established this CARA Net, which was a registry for clinical data for all children with rheumatic diseases. When you look at the enrollment across the board, it was very strongly juvenile idiopathic arthritis, dermatomyositis, and lupus. Then you got localized scleroderma, so 4% of the patients, so about 345 at that time. And then systemic sclerosis was one of the 1%, little tiny wedge there, so 64 patients. So this was about over a period of 3 or 4 years that data was collected and then summarized. And then my, fellow, and now she's attending in Indiana, Brandy Stevens, summarized the data, with us as a team here. And these are the overall demographics of those 64 patients, which was majority female. We talked about that a little bit. The predominantly Caucasian did have about almost 20% African American, and majority were non-Hispanic. And the age of onset of disease is around 10 years old. And there's about 3 years of disease before they typically would get enrolled into the study. And then most of the patients had ANA positivity and some of the antibodies that Dr. Moore was talking about. But the big picture I wanted to mention about this registry was just what we saw. So pretty much all of them had the baseline visit, is the orange, and their follow-up matched visit for ones that we had follow-up a year, 1 to 2 years later, is blue. So the majority at that baseline visit had a lot of skin findings, which makes sense, vascular Raynaud's, which makes sense, 92%, musculoskeletal, so some type of myositis or muscle inflammation or arthritis or joint limitation or inflammation, GI about 40%, pulmonary about 34%. And then very uncommonly, we'll have renal, like you might hear the adults talk about. Renal crisis that rarely happens in children. This 3% is not even renal crisis. It was just some protein in the urine. And cardiac, again, in children is much less common, thankfully, than the adults, so low percentage. So what I wanted to highlight is the follow-up 1 to 2 years later showed, overall similar skin and derm, skin maybe a little bit less, similar musculoskeletal, but big picture is not like a big change. So that's a good thing. Not all of a sudden we had all these new pulmonary or GI, a little bit, but nothing I would say statistically significant, just a small percentage. The 4% cardiac is not major cardiac things, a little bit of pericarditis or inflammation in the heart, 1 or 2 cases, a little bit of a different signal on the EKG, but no major myocarditis or inflammation of the heart. So that's the good news. Despite that multi-organ involvement, this was basically data over 50 person years. Follow-up is how we would describe that, and no new organ manifestations. So no new cardiac, pulmonary, renal, besides that like 1 or 2 little cardiac things, but not myocarditis, and no reported deaths. And then the other things that were noticed is the arthritis frequency went down and the joint contractures got a little bit better. And the dysfunction using ACR class of disability also decreased from 44% to 25% of those that had the higher disability decreased. And the global activity also got a little bit better. So that was just kind of an older cohort study. I wanted to just highlight on some things in the longitudinal data. Things we learned from that. We did a lot of quality of life studies within the CARA registry, and we looked at association of the quality of life. And in general, the quality of life from the kids at that time wasn't ranked very poor, only a few percentage. Most were thought they felt good or very good. But of those that, did kind of like scored that something was going on, we try to correlate it to pulmonary, et cetera. other organ manifestations. And GI is the thing that really stuck out across multiple patient-reported outcomes, was if the child had gastrointestinal issues, that they scored a little bit more poorly on these patient-reported outcomes across the board. So let's try to make that better. What can we do? We think this is happening because there's an impact on growth, lack of weight gain, not feeling well. So we started to collect across multiple registries to get a better idea of what's going on with these kids, what's going on with their GI system, how are they feeling? So in my cohort at the National Registry of Childhood Onset Scleroderma, in the CARA SCORE cohort, we're going to talk about, Seattle is also now doing a validation study, and internationally, we're starting to collect this GIT measure. So that is basically a scleroderma specific clinical gastrointestinal tract measure developed by Dinesh Khanna, an adult rheumatologist, for adults, but we're piloting it in juvenile systemic sclerosis. And in Seattle, we're actually starting a separate registry, a separate study to validate it, specifically in kids. So then we can publish and say, hey, this also works for kids on this, this, and this, but maybe not this question or that question. And then we can slightly modify it if needed. It asks a bunch of different questions in reflux, distension, bloating, diarrhea, constipation, etc. So there's lots of subcomponents to this. So we're really excited to start validating it. So Seattle is the main coordinating site, but our site and some other sites are doing this as well, in addition to collecting it in general in those different registries, as I mentioned it. So again, this is just an example how one registry data actually informs us, hey, there's an issue we need to address. It's the GI system, let's address it. So now we're moving forward with these other studies to get a better idea of what's bothering the patient. Now, this is another cohort I want to mention, is the international or Inceptions cohort. There are a few sites in the US that are participating, including my site. So my patients might be familiar. You hear me talking about my collaborator, Dr. Ivan Foldaberry, is the one that leads this in Hamburg, Germany. And he has a meeting every year that most of the docs that are on this meeting and call join as well. So basically, he's collecting across the US, but then also internationally, clinical data on juvenile onset systemic scleroderma patients. And you can see the breakdown of distribution of the centers. And so what are we learning from that? So in one of the publications we just did together, Best Practices in Research in Clinical Rheumatology, we kind of summarized older pediatric cohorts and this more kind of newer pediatric cohort. And we saw similar things we saw in the past, but what was newer is we did notice there is a little bit more pulmonary fibrosis or interstitial lung disease in kids than prior reported by kind of really digging in and looking at the data. So it is closer to about 40 or 44% of the patients. The good things that we saw is still very low renal crisis. There's actually no renal crisis specifically in the Inceptions cohort, and this has been going on for about 10 years. And the other good thing is the skin score is a little bit less than the adult counterparts. We did notice when getting more granular data, there is more musculoskeletal or like the myositis arthritis in kids compared to adults with scleroderma. So that also just kind of raising awareness there. So the summary is kind of in this publication I mentioned, and we talk about different updates as well. So again, another lesson learned. So from this cohort data, we said, pulmonary fibrosis, that's a little higher than published in the prior cohorts from the early 2000s. Now let's dig into this, okay? So we did. So we looked at that data in the kids. It was 150 at that time that were enrolled in the registry, and close to, I believe it was like 120 or so had complete data with that had pulmonary function tests as well as high-res CT to kind of put them together. And what we noticed is that the traditional cutoffs that we use for pulmonary function tests that Dr. Moore briefly mentioned, which are the FVC, the functional vital capacity, and the DLCO is the diffusion lung capacity. The normal cutoff is 80%. If you're above 80, that's like normal. If you're below it, like something, might not be going on. But a lot of the kids would have a normal pulmonary function test, but then looking at their high-res CT actually had interstitial lung disease. So this did bring it to our attention that we have recommended now, and this is a newer recommendation. It's something I didn't even recommend when I wrote a review 5 years back, that all juvenile systemic sclerosis patients that are kind of newly diagnosed and we're kind of working things up should get, as far as their field trip, as Dr. Moore recommended, should get a high resolution chest CT. And this does not need contrast. You can do it without contrast. But these are the changes in the lung that we're looking for, these interstitial lung disease. So that's, again, something, so appreciate any of you guys that have enrolled your children in these cohort studies. This is what we're doing with the study. If you're like, okay, great, Dr. Torok, but what are you doing with the data? This is what we're doing the data. We're informing clinical practice. So this is something we learned. This is just published in 2021. And I'm being presented at the prior ACR and then the ACR coming up as well, American College of Rheumatology. So we're spreading the word to the other rheumatologists as well. So this is the point, is the pulmonary function tests are very important. Keep doing it, but they're difficult. I mean, take a look. How easy is that if you're a 5-year-old to have your nose plugged, try to blow as hard as you can against this weird machine? And the therapists, they're awesome. They're doing their best to cheerlead on the patient, but sometimes it's hard when you're young. So, it's just, and you're in a box, it can be a little scary for some of the spirometry and plasmography. So that's why getting the baseline chest CT is also helpful, because these studies themselves, doing the PFTs are a little bit hard. So you might not even get like the full really understanding of what's going on in the lungs if you're only doing the volume originally. Following them over time, once you have that baseline normal chest CT, that's fine. Keep doing the pulmonary function tests. They are helpful. The kids do get better at it over time, I promise. We do also promote that they get all three things. So that's the plasmography, like the how well they can kind of expand and move things, and the spirometry is the volume as well. And then the DLCO is the exchange of that oxygen and carbon monoxide across the lung to see how well they're oxygenating. And I didn't mention it here, but 6-minute walk test we also are promoting. It is a little bit hard to do at some institutions, but putting that together with the pulmonary function test and the chest CT are helpful. So those are some things that we, again, learned from the cohort study and then kind of move forward. And now the next step. The next step is, there is obviously radiation in a chest CT, and that's why we were not originally recommending that for every single juvenile systemic scleroderma patient. But how can we make that better? How can we quantify the CT and also do less radiation? So there's an active study that's just getting started up. It's international. I know Dr. Foldavari in Hamburg is doing it. We're getting on board. It's led also by CHLA, Mikhail Sidon, a pediatric rheumatologist. Mayo is also involved. So there's a couple of different study sites, but we're trying to kind of quantify the CT a little bit better and use lower radiation if possible. But this is what we can do, is like with those imaging, get a better idea what's really inflammatory in the lung and what's more fibrotic, or that honeycombing. Why is that important? Because if you have more inflammation in the lung, you might want to use things that are more anti-inflammatory, like mycophenolate mofetil, Cellcept, Cytoxan, tocilizumab. That was just FDA approved for adults with interstitial lung disease. Whereas if you have more fibrotic or honeycombing changes, you might want to treat that patient with nanantinib. That's the newer tyrosine kinase inhibitor that was just FDA approved for adult systemic scleroderma lung disease. So, getting this data in pediatrics will be helpful. They do have some studies ongoing in adults, but so that's what we're kind of like feeding off of them. But getting that in the pediatric realm would be helpful. So if I approach you guys for this study, go ahead and join if you can. And then the Scorecard Study. This was a landmark study combining the forces and funding from the Scleroderma Foundation, and then helping out get scleroderma, both localized and systemic, back into the care registry. So this was awesome. We were so glad to partner these two teams, the Scleroderma Foundation with CARA, together, and it was led by myself, Suzanne Lee, and Ann Stevens. It's still ongoing. So basically, we're trying to look at both the clinical data that I've been presenting, but also with the serological or blood data. Like, let's put those two together to see, like, what are the immune phenotypes of these patients. So in addition to the clinical data, let's draw blood at these visits. So basically, it's a baseline visit, then every 6 months for 2 years. So you have 5 visits with full clinical data and full serological blood tubes that are processed by my lab, but then sitting there ready for the next investigator that comes by and say, oh, IL-17, there's a new medication for that in psoriasis. Is IL-17 important in pediatric scleroderma? Well, how can you look? Well, we have the data, we have the blood tubes that you can, apply, and if our scientific board says yes, that's a good project, then we can give that the de-identified samples to that investigator with the matching clinical data. So this is not just to promote the current research that Dr. Lee and I and others are doing, but then future to bank this blood for people for future use is just an awesome resource. These are all the people that are involved, 18 sites across North America. I am at Pittsburgh, the kind of the central site, and collect the blood, et cetera. And then Dr. Lee has been, her site in Hackensack has been collecting and housing some of the clinical data. And then it's all then gets fed and hosted at the CARA main registry as well. So these are the things that we're collecting in SCORE. So lots of clinical measures as well as patient global measures. And these are some of the blood analysis things. We're looking at cells, cytokines, antibodies, things like that. This is too in-depth for this conversation, but just bottom line, an example of one of the studies we're looking into. We want to see, is there blood markers that you can combine that maybe say, hey, this patient really has active disease. So that's the point of getting the longitudinal or the samples over time to see baseline visit to follow-up visit when the physician says, hey, they're really active to they're inactive. What changed? What biomarker changed? That's what we want to find out. So then we can see at the beginning, oh, that's the activity blood marker. And then for a new patient walking in the door a year later, we can say, oh, wow, your activity score is X. Maybe you need more aggressive therapy. So that's what we're hoping to develop with these kind of studies. Enmeshed in this study, not for systemic scleroderma, but localized scleroderma, we do have some consensus treatment plans that we validated in another study that we're also kind of collecting that data in tandem as well. And this is just a visit schedule. If you guys are enrolled, this is what you're doing. And if you're not, we are enrolling until December 31st. So get enrolled quickly if your site is one of those sites that was mentioned on the map. But we are collecting nice data over time. We have about 43 systemic sclerodermas enrolled and about 54 localized scleroderma patients enrolled. And then a little shout out for CARA newsletter that we published just about the biosamples, but just an example, 140 samples today from maybe a couple patient visits can yield like 5,000 individual aliquots, because we get the sample, for example, for sera, but then we section it into like 10 individual. So a patient that has one blood kit actually ends up having like 35 samples from that just one-time blood kit. So it just keeps multiplying, which is great for future research. So
Dr. Torok, a couple minutes left.
2-minute warning. So other things going on besides the SCORE CARA registry, a new project is an international collaboration. So this is looking at different ways to evaluate systemic scleroderma in pediatrics. We're wondering if the outcome measures that are used in adults, are they really applicable to pediatrics, or which are more important or less important, and what one should we kind of put at the top? So we're getting a bunch of experts, and this is the core advisory group you can see from both the US, but then also internationally, and kind of meeting together as experts in juvenile systemic scleroderma, going through the literature of the adults and saying, okay, what applies to pediatric? Let's start collecting in pediatric and seeing how these children are scoring or doing with these outcomes. So then when we finally get a clinical trial that comes to juvenile systemic sclerosis, we're ready to rock and roll, and we have the outcome measures that we think will change with therapy, and also that should be used for clinical, assessment across the clinics across the world. So next steps, let's fully validate these international outcomes we're looking at. There's lots of other things we're doing. Again, shout out, as Christina mentioned, to Scleroderma Foundation for offering this awesome opportunity for pediatric specific scleroderma research. This is the first time it's been earmarked for that. So I know that Suzanne and I and others have put in applications, so we're very excited to see where that goes. So thank you, Scleroderma Foundation. There is genetic studies that I'm doing. My coordinator's information is down there. This is what we call trios. So you get DNA from mom, dad, and the affected child, and siblings, if the siblings happen to be okay with it. Typically saliva spit is fine, but sometimes we'll get blood as well. And we're working with the NIH, so the National Institutes of Health. Dan Kastner is the main collaborator there. So this is kind of the breakdown. We're looking for genes that might be kind of different in the child compared to the mom or dad. And out of those 30 genes or so, we're seeing, do we find any of those variants in other kids with scleroderma? And then once we find those variants, let's look at the lab and see how they might be affecting cells and things like that. So just giving us clues to what's going on. And then last but not least, FDA approved 2 drugs for interstitial lung disease in adults, as I mentioned, the ninantinib and the tocilizumab. Definitely seemed to help. There's a tocilizumab figure. The interstitial lung disease kind of plateaued, where it, without the tocilizumab in the control group, it really kind of took a nosedive a little bit there. And then we're starting to do stem cell transplant. So here at the University of Pittsburgh, we have a protocol for 16 and older. The IRB modification is underway for 8 years old and older. And then this is presented at the Scleroderma Foundation National Patient Education Conference in July. This is our first 3 patients that underwent the autologous stem cell transplant for juvenile onset systemic sclerosis. This includes an 18-year-old young man, a 15-year-old young lady, and a 21-year-old young lady, all with different kinds of scleroderma. Some had the more classic, and another had more overlap. And then the third had more of the limited with bad lung disease. Just wanted to mention just real quickly that it's been 18 months, 6 months, and 2 months, or a little bit more actually, since I've done this poster, that these patients are out from the transplant, and there have been no serious infections, no serious organ dysfunctions. There's some reaction to one of the medications. But obviously this needs to be taken with a grain of salt. There's a lot of things that go into this. It is a risky procedure, but if done at a center that has a multidisciplinary team, we have cardiologists, pulmonologists, gastroenterologists, all dedicated specifically to this program. That the patients did well, and just from their words is basically one patient, Caleb, he said, "This is my rebirth day. I have so much energy and mobility. They're at an all-time high." And one of my friends, I think her mom's listening, Melissa, she said that it helped her tremendously for her lungs. She's able to do things that she hasn't done before, like going on her bike without gasping for air. And my friend Ari basically feels like overall her quality of her life has changed for the best. She can get up and move around much better than before. She's the one that had more of the myositis. So we're collecting more data, collecting more patients. So this is kind of just in the beginning stages of this. And that's it. Thank you, guys. This is the 2018, so the Kids Get Scleroderma 2 #2 picture. So you might see your kids a little bit older than the last slide that I sent. And this was us being goofy and dressing up with our Halloween outfits. So next time we are live, we will do that.